and welcome to another of our research methods and secondary data analysis webinar series. And as you know from the information about the webinar today, it is co-sponsored by the UAB Minority Health and Health Disparities Research Center, or the MHRC, the Deep South Resource Center for Minority Aging Research, or RCMAR, the UAB Center for Outcomes and Effectiveness Research and Education, or CORE, and the UAB Center for Clinical and Translational Science, or CCTS. And we are glad you're here. We'll send an evaluation form, a link to an evaluation form afterwards, and we'd love to get your feedback. And now I will turn it over to Dr. Olivia Clay, who will introduce today's speaker.
I was muted there, I apologize. Thanks everyone for joining us today. I know some of us are out of class already, so we appreciate your time meeting with us today. So I'd like to introduce our speaker, Dr. Shameka Cody. Dr. Cody is an assistant professor at the Capstone College of Nursing at the University of Alabama in Tuscaloosa. She's a board certified adult gerontology nurse practitioner, and Dr. Cody's research focuses on sleep health disparities and cognitive function in older adults with HIV. So I'm definitely interested in this talk because my sleep quality is terrible. She has a strong publication record in the field of HIV and aging. She serves as the principal investigator on 3 external awards and engages in interdisciplinary research with the UAB Biobehavioral Pain Lab here under the direction and mentorship of one of our RCMAR investigators, Dr. Burel Goodin. Some of her accolades: she was recognized as a 2020 Distinguished Educator for Gerontological Nursing, and that was by the National Hartford Center for Gerontological Excellence. And she's also a 2018 UAB RCMAR Health Disparities Research Education Program Scholar, a 2019 RCMAR Pilot Grant awardee, and a 2021-2023 Brown University HIV/AIDS CCRT Fellow. So we're definitely looking forward to your talk today, Dr. Cody.
Thank you so much, Dr. Clay. I hope everyone can hear me just fine. First, I want to just thank you for the opportunity to share my work with you and just really dig into some of the challenges that I encountered during the pandemic with recruitment of this special population, people with HIV. And that's kind of what I'll focus on, a little bit of my RCMAR pilot, along with my diversity supplement, and just some challenges and how I actually was able to overcome those challenges with my research team. So first, I want to acknowledge that my project was supported by the RCMAR, which was sponsored through the NIA, National Institute of Health. So I want to acknowledge that and just say that the content does not necessarily represent the official views of the NIH. So first, I think it's important to talk about why I'm interested in doing this work. And so my background being in gerontology and my research being focused on people with HIV, we know that people are living a lot longer, which is a beautiful thing. There are less opportunistic infections, mortality and morbidity rates are definitely decreasing. But then we have to look at those who are virally suppressed, and we have to ask what's next after we actually get them managed on medication. We have to look at quality of life. And so we have 2 groups of older adults with HIV. We have those who are actually on antiretroviral therapy and virally suppressed. And then we have those who have a late diagnosis of HIV. So that's even problematic if they're now in their 60s and they're having a new diagnosis. So those present different challenges. So most of the work that my research team has focused on is looking at comorbidities and just the burden of HIV and these age-related conditions. So the World Health Organization looked at HIV and aging, but mostly ending the AIDS epidemic. That's kind of the new thing. How do we actually end the AIDS epidemic as a public health threat? And the goal is to end that by 2030, majorly by targeting the 90-90-90. And so just to kind of give you a little background, the goal is that 90% of people with HIV will actually know their HIV status. And also the second 90 would be 90% of people with HIV who are diagnosed, they'll actually be on HIV antiretroviral therapy. And then the third 90 is that 90% of people with HIV who are actually on medications for management will actually achieve adequate virus suppression. So that's the 90-90-90. Well, there is definitely a fourth 90, which focuses on quality of life. And there's a body of research that looks at that fourth 90. And that proposes that those who are actually virally suppressed, like what's next? How do we ensure they have a good quality of life? And so it focuses on comorbidities, even self-perceived quality of life. And the reason being is that even though the focus is no longer on survival, it is now on quality of life because there are high reports of symptoms among older adults with HIV, even though they're virally suppressed. So the ultimate goal is not just adequate virus suppression. It doesn't stop there. It actually goes beyond that to look at quality of life for this unique population that's continuing to grow. So how do we proactively address these comorbidities? So as people with HIV kind of go into their 50s, 60s, and 70s, again, virus suppression is not really the ultimate goal of treatment. We have to look at these non-communicable diseases. And so these are things like sleep and cognitive problems in those who are aging with HIV. So you have the age-related effects, and you also have the HIV-related effects that kind of just stem from inflammation and just the virus itself. And so there's a body of research that looks at people with HIV developing these comorbidities like heart disease, diabetes, even cardiovascular disease, developing those comorbidities a lot earlier in the lifespan. And also, there's another body of research that looks at the comorbidities in this population being more profound, the effects being more profound. And so the biggest challenge with clinicians as they treat more people with HIV that are older is how do we isolate the HIV-related conditions and the age-related conditions? Very difficult to do. And so we need more integrated care. So my research focuses on sleep problems and cognitive declines. So just a little bit of background in my PhD work, it was mainly just on cognitive declines, but I became really interested in the effects of sleep. And we know that sleep has a big effect on immune function, as we've seen even during the pandemic. So next, I want to talk a little bit about HAND, which we call HIV-associated neurocognitive disorders. So HAND is very prevalent in those with HIV. Nearly 50% of people with HIV have these neurocognitive disorders. And there are several things that can contribute to HAND, one being inflammation in the brain, which is kind of just fueled by the HIV virus itself. And you have these white blood cells that secrete these toxins that enter the central nervous system and affects the brain. And so even these subtle differences in these cognitive impairments can actually cause impairments in everyday functioning tasks. So decision-making, taking their medications, even a whole body of research by Vance and colleagues looking at driving. And so this is very important to look at because as we move toward virus suppression, we have to also look at some of the things that could impact that, and cognitive function being one. And so there's neuropsychological testing that looks at different domains of cognitive function, and they're listed here. And so two things I want to mention is as adults age with HIV, they're more likely to develop these comorbidities that could also contribute to poor cognitive function. And then also, again, like I mentioned on the previous slide, the effects of HIV and aging when they come together can increase one's susceptibility to not just HAND, but these age-related neural conditions such as Alzheimer's. So just a little bit more about HAND. There's different levels to HAND from mild, asymptomatic to severe. So about 2% of the population, because of medications and other advances, now have HIV-associated dementia. So that's a big difference than earlier in the HIV epidemic. And so HIV-associated dementia is the most severe form of hand. And again, you have impairments in 2 cognitive domains, at least 2 standard deviations below the norm, but you have this marked impairment in everyday functioning. So decision-making, also judgment, memory, and those types of things. The majority of our HIV population is going to fall in the mild to asymptomatic categories. In the mild neurocognitive disorder category, you still have this impairment in 2 cognitive domains, but it's 1 standard deviation below the norm. You have some impairment in everyday functioning, and then in the asymptomatic, you have no impairment in everyday functioning. And again, those who are asymptomatic, they could function normally like us. But as time go on, they can notice little things like, oh, I'm forgetting to take my medication. I'm forgetting my clinic appointments. I can't really make decisions like I used to. And it's these little things that over time can tend to progress. And they actually, they can have things like depression. There's even behavior indications of hand. And so again, half of the population is now falling in these mild to asymptomatic categories. But again, these subtle differences can actually impact quality of life for many people that are aging with this chronic disease. So I wanted to highlight here that there are several things that can impact cognitive function. And as you can see here, social engagement, substance use, nutrition, there's just a body of research that all of these things collectively and some independently can have an impact on cognitive function. The reason why this is so important, because we already have a cognitively vulnerable population, people with HIV. As they age, they can encounter even more comorbidities that could affect their cognitive function. But this cognitive impairment can impact their ability to be adherent to their medication, which is important for virus suppression. And so the one thing that I am choosing to focus on is sleep quality, okay? So now getting into the meat of my work, I'm looking at sleep quality in older adults with HIV with my RCMAR Pilot study. I kind of made this little diagram so you can kind of see kind of my thought process of where I would like this work to go. So there is a body of research looking at cognitive function and sleep, and it's been shown that there could be a directional relationship between sleep and cognitive function in people with HIV, meaning those who have poor sleep, and it's different measurements of sleep. So duration, daytime sleepiness. When we talk about sleep quality, there's several compartments to sleep quality. So there's sleep duration. There's how many times you wake up in the middle of the night, how long it takes you to fall asleep. All of those things can affect cognitive function, and there are some studies there that show that. Also, there are some studies with my mood and things that kind of look at learning and memory impacting, being impacted by sleep, and it's looking at HIV positive versus negatives and racial differences in this population, as well as comorbidities and how that plays into cognitive function and sleep. And then mood. Mood is another outcome that has been associated with sleep, and there are studies there. Substance use is another outcome in people with HIV that has been correlated with sleep. My RCMAR pilot focuses on the relationship between sleep and cognitive function, looking at different domains. So looking at memory, looking at decision-making and executive functioning, looking at speed of processing, so how fast your brain can process information. So it looks at all of these domains and how it relates to not just subjective forms of sleep, but also objective. So looking at actigraphy monitoring and sleep diaries. So that's my RCMAR pilot. But also there is another component, there's chronic pain. Chronic pain is now considered a comorbidity, just like insomnia and poor sleep. And so my diversity supplement, I'm working under the leadership of Dr. Goodin. It is focusing on sleep quality, but also focusing on what that looks like in people who are taking opioids. As you know, that could definitely affect cognitive function. And so that section with chronic pain is also related to mood and substance use. But the big gap that I would love to fill with my research going forward is to look at how chronic pain affects cognitive function. And so that's kind of the trajectory that I'm trying to go. So the RCMAR project research aims, I want to look at feasibility of the study procedures. Now, we know this is a hard to reach population. And if you reach them, it's hard to retain them. It's hard to get them to keep coming back for their study visits and even clinic visits. I want to look at attrition rate and participant recruitment and just, are they able to adhere to the protocol? That was just the feasibility part. Second part is I want to look at the relationship, as I mentioned earlier, between sleep quality and cognitive function, using these subjective measures like questionnaires and also objective measures, which would be actigraphy monitoring to look at sleep and also looking at sleep diaries. So these hypotheses I generated as I started to begin to think about studies. I really, there's a body of research that has, and it's mixed findings that shows objective and subjective measures of sleep correlating with cognitive function. We know that increasing age is going to predict worse cognitive performance and sleep quality in people with HIV. Definitely already know that. It's already been shown in the literature. The beauty of this study is a lot of my patients are also recruited from rural Alabama, as I'm here at the Capstone College of Nursing. So I've gotten patients that are in rural Alabama, and sleep may look very different in rural Alabama. So I'm very interested to see the geographical differences as well. The second thing, hypotheses, is I want to look at these cognitive impairments and look at different domains to see if they will correlate with greater insomnia severity and also poor sleep quality measures. And the reason why I want to look at that is I want to see the impact in these types of things in people even with HIV-associated neurocognitive disorders. So now I want to get into kind of the methodology and recruitment. So this was pre-COVID. Pre-COVID, my target sample size was 60. I was looking at people age 50 plus. Inclusion criteria, I was looking at those who are African-American versus Caucasian. They had to be diagnosed with HIV for at least 1 year. Because the effects of a new diagnosis of HIV could definitely impact things like mood and judgment and those types of things. So I want someone at least diagnosed for at least a year. And that's been kind of consistent through the literature. And then there's some exclusion criteria. So, currently undergoing radiation chemotherapy, all of these things that could affect cognitive impairment. I definitely wanted to exclude those individuals. So now during COVID, I had to do a few modifications, but my recruitment methods were usually through peer recruiters. And these are people with lived experience of HIV. And they can actually, they're what I call my extensions. They can actually reach the population and be more effective because they have lived experience. They're peer recruiters. I am thankful for peer recruiters because a lot of the conversations that we think may be easy to have, they're very difficult to have with this population. And so the peer recruiters actually facilitate that communication and building that relationship. And so the peer recruiters were very helpful in this recruitment process. Word of mouth has always been a way to recruit participants. Healthcare providers, well, when COVID hit, a lot of the clinics did close and they did telehealth. So that was another way to, hey, can you mention some of our studies in your telehealth conversations, especially mental health providers, because there's a close relationship between mood and depression and sleep. And so that was another way. And then the biggest thing that really worked was shared recruitment. And so if you have collaborators who have studies in the similar population, to have a shared recruitment was very effective, especially during the pandemic, because it lessens the amount of visits to the site where they have to actually do the research. They can actually come and they can do multiple studies in one day, or, they don't have to, have transportation issues more than one time. The recruitment sites were UAB 1917 Clinic, Five Horizons, Watley Health Service in Ames, Alabama. And I am very grateful for these sites. Even during the pandemic, I was just really surprised at how the recruitment actually kept going. It was very successful. And one thing that was very important to me was transportation was an issue, but it was also just when the pandemic first started, it was just the fear of the unknown. You know, being immunocompromised, and then there was no vaccine available at that time. And even when the vaccine became available, they were still afraid. They wasn't quite sure if they wanted to take the vaccine and come. So it was just a lot of challenges for this population that was immunocompromised. And if anything else, one thing I can say is it really made them focus on sleep. Once I actually told them how important sleep was to building your immune function, they were like, oh, I need to get some sleep. So I made a few modifications during COVID, and I used all of these methods. The one I would have to say that really worked were the peer recruiters and the shared recruitment. All right, so where am I now in my recruitment? So this study is still ongoing, right? So I've enrolled 36 participants, and I've had 2 participants drop the study. And mainly because transportation was kind of a big barrier, having to come back to the site, but also I would have to say mental health, mental illness, some of the challenges with mental health. We've seen mental health disorders kind of drive up during the pandemic, along with substance use. So that's kind of been another issue with some of the participants. But so far, I've had 34 participants complete the study, and I think this is a big success given the barriers that have happened with the pandemic. So just kind of going into the methods. So this study started in 2021 in January, and it is still ongoing. And this was pre-COVID, the first step was a telephone screen. And so the telephone screen was just to see if they're eligible for the study, kind of going through all of that inclusion, exclusion criteria. If they're eligible, they would come in for a 2-hour visit. And then beyond the 2-hour visit, when they come in, they would do phase 1, which was a neurocognitive battery, which was just a set of questionnaires and cognitive tests. And then they would do a 7-day actigraphy monitoring with sleep diary. They would wear the watch for 7 days. It would monitor their sleep. They would complete a sleep diary. When they returned the diary and the watch, they would be compensated. And so that was phase 1 of the study. In order for them to proceed on to phase 2 and even phase 1, they will have to complete SBSM, which is kind of a short, brief questionnaire to make sure they don't have severe neurocognitive impairment, because we don't want those with severe cognitive impairment to be in the study. We want those with that mild. And again, that's only 2% of the population. So I haven't had to exclude anyone because they had severe cognitive impairment. Phase 2 it consists of a subsample. So 30 of the 60 participants, we were looking to put them through a task-related EEG, which is where they put the electrodes on the scalp and it monitors the activity in the brain. And so it's a task-related EEG ERP. They would do exercises on the computer, kind of cognitive task, and put the electrodes on. And as they're doing the exercises, it will look at activity in the brain. And so that was kind of our objective measure of just kind of activation of brain areas and correlating that with sleep. So because of COVID, we removed that part of the study. It was just a lot of problems with people coming in for transportation. The COVID protocols kind of prevented, being able to move ahead with that study. And I've also had some changes in the structure of my research team. So I've had several barriers to where we've had to actually take out the EEG portion of the study. So we are looking to continue that part of the study with larger funding at this time. So moving on to the protocol, I won't go over all of this, but I just kind of briefly show you. This is the study protocol, and the name of the study is Asleep. And they always say, am I going to be put to sleep? And I go, no, I'm not going to be put to sleep. But this is the protocol, and it was 2 hours, 2-hour protocol, and it's several questionnaires. And then at the end, they get the watch and they wear it for 7 days. So now modifications, that was the original protocol. So during COVID, I made some modifications so that I can make my data collection process more successful. 2 hours in the Campbell Hall building is a long time during COVID. And I wanted to decrease the amount of time that the participants had to be in there during COVID, because one is it's fearful and they're frightened. So I reduced my time to 1.5 hour visit. And sometimes it ran kind of right at 1 hour. I mean, I was kind of surprised. So I would send questionnaires home with the participants. Now, here's the problem with sending questionnaires home. I would ensure that none of the questionnaires had HIV on them, because it could lead to a unintentional disclosure of their HIV status. And I would always ask, are you okay with going home with questionnaires that say HIV? And I would document that. But really none of the questionnaires that I sent home with them had HIV on them, just to protect the participant. I would do telephone check-ins with the participant after 3 days to see if they had questions about the watch, the sleep watch, or the questionnaires. Because again, when you send them home and you know there's a lot of issues with health literacy and understanding the questionnaires, you really want great data. So I would do check-ins and I would say, hey, any questions filling out the questionnaires or even wearing the sleep device. And then I provided prepaid postage where I could track the package for them to send in their paperwork and actigraphy watch. And this was very successful. This was something that I did during COVID and it worked. I got all of my watches back. I got all of my questionnaires back. No one kept them. But when they bring their watch and questionnaires, that's another visit that they will have to come into the building. And so that's a transportation fee. And then it's the fear of, I don't want to get sick. I don't want to get COVID. So it was just too much. And so I think this worked fairly well. When I did the check-ins, twice. And I also let them know, hey, I received your package in the mail. I received your watch and your paperwork. And so this was very successful. So I just want to share some of the changes I made during COVID. Some other things with COVID-19 and sleep quality that we have to acknowledge is that social distancing can affect sleep quality. So as I analyze this data, I have to think about other factors that could affect the findings. And so social distancing, there is a body of research that looks at social engagement and how that really helps with cognitive function and sleep. Anxiety and stress. And as I mentioned, with the drive in mental health disorders, and also the drive in substance use disorders, all of this can play into sleep as well as cognitive function. Changes in routine. The gyms closed, so whereas you have some people that may have exercised at the gym, they can no longer exercise at the gym. So that could affect their sleep quality and their cognitive function. Even employment, and Dr. Vance and I have papers out on this that shows the benefits of working in this population and just any population, the benefits of employment on cognitive function and sleep. So that could impact it. Lack of sunlight, so vitamin D. There's a body of research shows the benefits of vitamin D on sleep. Grief and loss, that's another area. And then there is a body of research on vaccination response that shows that those who get less hours of sleep actually do not respond well to the COVID vaccine. It could be a delayed response. And so that's something else that we have to consider with vaccination response. So I just want to point out these areas that I'm considering as I analyze the data. So now my sample description. Again, we have 34 participants. My targeted number is 60. So I'm about a little bit over halfway there. It's not surprising that majority of our population was African American. I'm actually definitely looking at rurality, given some of our participants were recruited from Five Horizons as well as Watley Health Services, which is in Tuscaloosa. And then also it's not surprising that over half of the population are disabled. That is pretty consistent through the literature. All right, so I looked at sleep disorders in my sample, and insomnia was still number one. 64.7% of participants had insomnia, and insomnia is defined as difficulty falling asleep, difficulty staying asleep, and waking up too early or waking up too early. These symptoms persist for 3 months or more, and it's chronic, and it happens at least 3 to 4 days out of the week. So that's the definition of insomnia. And so majority of these patients had insomnia. And also obstructive sleep disorder. This is a hot topic right now, especially as we look at social determinants of health, and we look at the African-American population being disproportionately affected by HIV. We also have to look at other conditions that disproportionately affect this population, and obstructive sleep disorder is one, especially in the Deep South. So the correlations, I kind of did some little preliminary analysis. And again, this is ongoing, but I just kind of want you to see where my data is going. So correlations between sleep and cognitive function and everyday functioning. So as you can see here, insomnia and sleep quality correlated heavily with depression, which is that's not surprising. But also executive function, which is measured by this TRAILS-B, is also correlated with everyday functioning. And so executive function, again, deals with planning and decision making and kind of higher level cognitive function. That correlates with the EPT, it's the everyday problems test, and it measures things like their ability to follow directions, their ability to follow recipe, ability to read labels on canned foods and medications. So it is a 26-item test that measures their ability to problem solve and do everyday things. And we know patients have to read labels for conditions like diabetes and blood pressure. And so that's important. And also reading the labels on their medications is important. And so the fact that that planning and decision-making correlates with, everyday function is not surprising as well. And then working memory, which is measured with the WISE, WAIS. Working memory correlates with everyday functioning. So as you can see here, none of these subjective cognitive measures correlated with sleep. So if you look at the TRAILS-A, which measures like attention and speed of processing, TRAILS-B measures executive function, the WISE measures working memory, none of those correlated so far with sleep, okay? So just to dig a little deeper into the results that I just presented, as you can see, sleep and depression, there is a positive correlation, which means those who reported depressive symptoms or scored higher on the depressive scale actually had worse sleep. They had worse quality of sleep, and the severity of their insomnia, which is measured by the ISI, was worse in those with depressive symptoms. So this actually, it actually guides our research, because most of our research at the Campbell Hall with the Biobehavioral Pain Center is on insomnia, again, which is the most prevalent in this sample. Now looking at everyday functioning, executive function, working memory, kind of digging into those correlations on the previous slide. As you can see here, those who actually performed better on that WISE questionnaire, WISE testing, which measures working memory, they actually had better everyday functioning scores as well. And then with the TRAILS-B, those who actually performed better on the TRAILS-B, meaning they were able to complete the task faster, because it's a timed task. They were able to complete the task faster. They actually had better everyday functioning. At the same time, those who took longer to complete the task, which indicates poor performance, had worse everyday functioning. So now data collection continues so I can reach my targeted sample of 60. As I mentioned, the subjective measures of sleep quality, which was the PSQI and the insomnia severity, there's no correlation so far with those cognitive function domains of speed of processing, executive function, and working memory. And also the objective, which was the actigraphy data with the watch and the sleep diaries, we're still analyzing that. So you see a question mark there, that is still ongoing analyses. Now, one thing I want to point out here is this is a small sample size. Right now, I only have 34. I'm looking at 60 as my target sample. Also, I'm still recruiting. We still have some more analyses to do with spatial and verbal memory, so other types of memory. So that part is missing here. And then also we have to do the actigraphy and sleep diary analyses, which is our objective measures. And there is a literature that shows correlations between objective measures of sleep and different domains of cognitive function. So I hope to present all of these findings in the fall, if willing, so you can kind of see exactly the full picture of how these subjective and objective measures of sleep correlate with these different domains of cognitive function and what that actually means for people with HIV-associated neurocognitive disorder or HAND. So lessons learned, okay? So some of the lessons learned, challenges in this population. This is a very challenging group. I absolutely love this population because of the challenges. It always pushes me to think outside of the box and try to figure out how can I get them to come and see me. And honestly, I've been just so happy that this population have been so receptive and just so receiving of my team. One thing that I definitely recommend is to anticipate some of these challenges and kind of think about the solutions on the front end. How will you overcome these barriers prior to beginning the study? So transportation, there are ways to budget that in now into your grant proposals. You can budget in for transportation. Improper wearing of the sleep devices. Now, this has been an issue that we've had, not just with this study, but with also studies with my research team with a diversity supplement that I'm working on. They're doing some sleep apnea home testing. And so one thing that we are working on and we've been doing is written instructions. So giving written instructions, even pictures seem to work better. So if you have pictures of how the sleep devices are supposed to be worn, it's easy to look at the picture and go, my device does not look like that, versus trying to read a paragraph of information on how do I put this on. So pictures are best for this population. Also check-ins, which I've mentioned that I incorporated that with my methodology changes. So calling on the phone and checking in. Do you have any questions? Call me anytime. You know, can I answer any questions about whether your sleep device can get wet or not? You know, they may say, I took it off because I put it in the shower. Oh, no problem. Put it back on, dry it off. So just those check-ins, they want to be reassured that they're doing everything correctly. And then participant teach back. If they can teach you sometimes what you taught them, it works. That's just not a clinical thing. That's a research thing too, is can you tell me now how you're supposed to wear your sleep watch? And so participant teach back. HIV-related stigma. So looking at ways to reach the population in the most effective way is definitely a goal of mine. It's more than recruitment, it's relationship building. These psychiatric comorbidities have been challenging in this population. And this is where we can really look at integrated ways to collect data. So even some of my colleagues that are working with this population, if they're working with mental health, then that's the way they can collect sleep data and vice versa. Sleep data can be collected with mental health data. So just kind of reducing the burden of the questionnaires is a good thing. Recruitment methods. We got to look at non-traditional recruitment strategies to attract this vulnerable population. So we have to go beyond the clinics at this point. It's the clinic to community approach. And I have kind of really exercised that in my journey as an early career investigator. And so mobile data collection works well. Looking at faith-based organizations and how you can get them involved, and community health fairs work well. Shared recruitment, I talked a little bit about that. But again, it's about relationship building and even doing a needs assessment of the population to figure out what matters to them most, and integrating your data collection with the needs of the population, letting their needs drive your data. And that's something I've really, I've been thankful for my mentors for really, hounding that is, hey, let their needs drive your data and you'll have a better outcome. Collaborative team, consider ways to promote team science and keep people engaged. And the structure of your research team can change. And I will tell you why I put this in here. Bi-weekly team meetings are helpful. And also knowing what to do when a collaborator leaves the project. So during my RCMAR, I had a collaborator who transferred to a different institution, and it was for my EEG portion of my project. Well, that was the part 2 of my project. So you can imagine, as an early career investigator, I went, oh no, what am I supposed to do now? But you have to think about what is the most effective way to collect the data that you need so that you can move forward. And it can be done, you can move forward. And so just always consider other ways you can collect the same data so that you can actually answer the questions that you really need to answer. It does not always have to be EEG. Sounds very innovative and sounds great, but we have to do what's feasible for the population. And during COVID, EEG was just not feasible for them. So just a slide on a diversity supplement. So I have a diversity supplement that's through the National Heart, Blood and Lung Institute with NIH. Parent grant PI is my wonderful mentor, Dr. Burel Goodin, and I'm the sub-awardee, and it's still in progress, but specifically this project focuses on insomnia in people with HIV and chronic pain, and really looking at the role of opioids. So opioid actually making chronic pain worse, right? And we know opioids play a role in respiratory depression, so it can actually make sleep worse. And if you remember, I just told you obstructive sleep apnea is a problem. So this is just a really great project, and it really adds to how we can manage chronic pain in this population and really look at drivers of sleep in this population. The data collection is ongoing. We've done a little pilot work looking at brief interventions for sleep and chronic pain. And so we're really looking to fold this into a larger grant proposal here pretty soon. So scholarly trajectory and next steps. This has been a wonderful journey with the RCMAR pilot and with my diversity supplement. So recently, I am just excited that I was awarded early tenure promotion to associate professor, and it's effective August 16 of this year. A huge milestone, I'm gonna cry, a huge milestone for me, but it really speaks to why I want to continue doing this important work. I've had some great mentors actually pour into me and support me along the way, along with my dean. And so one of the biggest things I can definitely say is that the methodology that you propose is not always the best for your population. And COVID was definitely unexpected, but it forces you to think outside the box and go the non-traditional routes of recruitment and actually retaining your recruitment sample. And so my goals is to finish data collection, continue building my team, which that's an ongoing thing. I'm disseminating a lot of the research findings right now, and the ultimate goal is to submit an early stage investigator R01 proposal. And we're also looking at some inflammatory markers and things like that dealing with sleep. So last, I want to just thank my entire research team. I call them my entire research village. Every individual on this slide has contributed to my work in such a meaningful way. Every person on this slide, I have really enjoyed just the interdisciplinary approach to building my program of research, and I continue to learn each and every day. And this has been just a great experience. And now that I have some of my findings, I am, we hypothesize and we actually say, well, why? We ask why this population have this problem, but now I enjoy the whole idea of why my findings are the way they are and how that guides future research. So that's even the more exciting part is why now do I have these findings and what are we going to do about it next? Because we still have to ensure again that this population have a great quality of life. So thankful for my research team, and I just wanted to acknowledge every person on this slide. And I am happy to answer any questions. Thank you so much.
Thank you so much, Dr. Cody. That is a great presentation of your information. And I loved how you talked about the progression and the challenges with the pandemic and COVID-19, and how you were able to, as people did, pivot and innovate and do new things, do beyond what you had originally planned in order to accomplish the goals. And yet it did set people back because of everything that happened with it. But it is great that you persevered. So does anyone have any other questions? I have one. Oh, good. And there's Dr. Vance. Do you have a question or comment?
Yeah, I do. For one thing, Shameka, this is great work. And I really love the epigraphy. I think that is very novel, and I'm really excited to read about that at some point. You said you're still recruiting. What is your age cutoff?
I don't really have an age cutoff, but I think it's 50 and up. So the oldest participant I've had is 70, 72, 73. That's been the oldest.
Well, if you send me your flyer, I can send it out to my friends.
Yes, I would love to.
Yeah, so okay. So anyway, fantastic. I'm glad you're doing well. This is wonderful.
Thank you.
So, and I also was thinking while you were talking about it, I was glad that you talked about the further investigation you're considering with COVID-19 and some of the similarities with the symptoms and things that we're developing with the HIV population, and how they also are developing and things that are happening with people who have COVID-19, which then is a much broader group of the population. And it's important to be thinking about all of that, how things that may happen. So some people may think, well, I don't have HIV, so that doesn't affect me, but we could get it, and we could get COVID-19. And so there could be effects that that reach even more people. So it's important to be studying ways to address them. So thank you for all of the work that you're doing and continuing. So, and I see that okay, we've got a couple things in the chat box. Congratulations on your early promotion.
Thank
Yay,
you.
That's great.
Thank you so much.
And then thank you so much. Such a great talk. Everyone, there's a link to the survey in there. And we'll also email that out. That's in there twice. And then a question, how do you recruit hard to reach people with telephone survey?
So we did flyers, of course. And we also, we did some, again, the peer recruiters were actually able to recruit, and those are peer recruiters identified through the clinic at Five Horizons. And they're kind of, the champions, they're HIV champions, and they're very well connected, and they actually can, recruit for us and actually bring people in for us. And then the telephone, as far as the telephone screening, that was just a brief screening over the phone to see if they're eligible. But then if they're eligible, they go ahead and come in for the 1.5-hour visit. So we did flyers, but we also did a lot of boots on the ground work and a lot of peer recruitment. Yeah.
I have a quick question, Dr. Cody. So you were mentioning one part of your study that you didn't get to do. Was it the EEGs you were mentioning?
Correct.
So at the point we're at now, is that something that you could potentially add, or if you have resources available, or kind of what's your plans?
I think where I am right now with the RCMAR pilot data, I think we are kind of at the end of the period, and I think a better focus would be to try to get the rest of my sample.
Gotcha.
And then as I get ready to submit a competitive R01, maybe look at that as like another part, and it's, expansion of what's already been done. That's kind of building on the pilot data. I think that's probably best at this point.
Okay.
So, and I thought of a question for Dr. Clay and Dr. Vance, I think, and then with Dr. Cody as well. So thinking about the flyer and recruiting, would it be appropriate if we sent the flyer to our whole distribution list of participants to this research methods webinar series? So it's a broad audience, but of researchers, and we could do it with other studies that are presented in the future. But do you think that would be okay?
Yeah, I definitely do. Like I said, we appreciate Dr. Cody's time, so I think we could definitely do that to distribute it to our networks.
So if you're interested, so it's a lot of researchers, you know, a lot at UAB and other institutions that we partner with who have joined this this webinar series over the past few years. So, okay, and I saw a thumbs up from Dr. Vance.
Thank
So
you
great.
much.
So if you'll send that to us. And our team here, let's note that for the future that we could offer that to our other presenters as needed for those who are still recruiting. Okay. Oh, so Azad Bhuyan, Dr. Bhuyan from JSU, thank you for saying who you were. I didn't recognize from the letters and numbers. And then question, do you think subjective measure of sleep quality is not good?
I can't say it's not good because there has been some great, it's a body of literature that's shown that it's been, that it correlates well with cognitive function. But what I found is that that in this population, people who really think their sleep is great is not great. So they either underreport, or I'm gonna tell you something else, they over-report. So they may confuse something like them being in pain with poor sleep. So that's been confused because people take their pain medicines to help them sleep. They don't really take it for pain sometimes. They say, I took my pain medicine at night, but they know it's for pain, but some people take it just to help them sleep, to get off to sleep. So that's been another issue. So I think a combination of, you need subjective and objective measures to really get the full picture of how someone is sleeping. And really you need an environmental scan of their sleep environment, because we know this population sleeps in different environments, from couch to couch, from homeless shelter to different places. So that's something else that I'm really excited and interested to do, is the environmental scans of this population in their homes and where they sleep. So.
Thank you.
You've got a message from Dr. Allen in the chat saying what sort of information was recorded in their sleep diaries.
Thank you. I was muted. I was trying to read it. I was reading it, but I was muted. Sorry. Thank you for doing that.
And so sleep diaries look at caffeine intake. It looks at exercise, what time they wake up, what time they go to sleep, how long it took them to go to sleep, how many times they woke up in the middle of the night. It also looks at what they did before they went to bed. So if they read or watch TV or use their electronics or whatever they did before they went to bed. And I said caffeine intake. So it kind of looks at some of those behavior things that could impact sleep.
Great. What else? Any other questions for Dr. Cody? We are approaching the top of the hour. So, and I see Dr. Allen's response. Got it. Thanks. So thank you to everyone who participated today, and many, many thanks to you, Dr. Cody, for your presentation and your ongoing work. We appreciate it.
Thank you.
And reminder, so our ongoing research methods and secondary data analysis webinar series, we are including then a secondary data workshop coming up next month. So it will be on Friday, June 3rd, Dr. Peter Baltras from Morehouse School of Medicine will be leading an NHANES workshop, looking in detail at the data and that's available for analysis and different ways to analyze it. It's a 3-hour workshop on Friday, June 3rd, starting at 9 o'clock Central Time, 10 o'clock Eastern Time. And we'll be sending out more information about that through our email distribution list. But we hope that you will attend if interested, or forward the invitation to it to others who might be interested. And then we are off for the summer. We will not have this webinar series during the summer months, but we will reconvene next September for September, October, and November. And we are still determining the speaker schedule for those dates, but they'll be the first Thursdays of the month at this time. So, and be sure to give us some feedback on the evaluation form at that link, and we'll send that as well. Anything else before we wrap up?
Thank you so much.
Thank you too. All right, bye everyone.